Recording.
I think that's recording now, is that right?
Yes, perfect.
Let me downsize you. Okay, so thank you everybody for coming. Tonight's webinar is talking about pulp treatment in pediatrics, which as you will know is between 0 and 16. So as a background to me, I'm working at University of Manchester at the moment as a consultant professor in paediatric dentistry. My undergraduate training was in the University College of Cork, and I don't know if any of you are here tonight, and I did all my consultant training in Leeds, so all 5 years to specialist level and to consultant level. Now, there should be a little poll just to find out where all of you are from. Let me just quickly launch that. So can you all, yeah. Oh, people from all over tonight, that's great.
How do I go?
Manchester, Leeds, Liverpool, Sheffield, Newcastle. I think I've left out some because I was only allowed to use 10. So sorry if I've left out your university. No voting. Okay, so mostly Manchester and yeah, some from Scotland, Cardiff. Brilliant. Which year? Oh, look, we've got some year 1 and 2. That's really good. Lots of year 3, 4, and 5. And most of you like Quentin Tarantino. Well, that's really good because I think you can see where this is going, hopefully. Poll. So a lot is said about pulp therapy, particularly in the primary dentition. And tonight we want to have a little look at what is the truth about pulp therapy and what is pulp fiction. So just an overview and a look at what's ahead. This is a picture that I took in Death Valley in America, showing the road ahead. And tonight we'll have a little look at lots of different things. So pulp therapy in primary teeth, first of all, why would you restore them at all? What's the difference between primary and permanent teeth, anatomy-wise? Making a diagnosis, and then we'll just go through the different forms of pulp therapy you could use, whether or not you should. We can discuss that. And lastly, we look at different ways of managing vital and non-vital immature permanent central incisor teeth, because sometimes that can be a cause of a lot of confusion as well. So why restore primary teeth? It's a question I'm asked a lot, and it's something you'll be asked a lot by parents, and sometimes by the children themselves. And they might say, well, their primary teeth, they'll just fall out. And why not just leave them? And if they're not causing any pain, do we need to do anything about it? So do we need to restore them, or do we need to extract them? And the answer is, there's a lot in the literature to tell us that actually we do need to treat primary teeth that are decayed. It tells us that children with multiple decayed primary teeth eat less, they have disturbed sleep, and they're shorter often than their peers, not just because they're eating less, but because when they're awake at night with toothache, they're not secreting all the growth hormones they should. And in fact, what's really interesting in the literature is that children who are shorter than their peers, they exhibit what we call catch-up growth when we treat decayed primary teeth. Whether that's by restoration or extraction, they catch up to their growth centile, which is fascinating. And overall improvement in oral health-related quality of life. So that is improvement in achievement at school, smiling, socializing with peers, things like that, when they feel their teeth look good. And this is a very interesting paper by Thomas back in 2002. And they looked at children before they had their teeth extracted or restored and afterwards. And you can see the huge difference. So complaining about his or her teeth went from 56% down to 2%. Chewing problems, you can imagine, went from 60% to 8%. Limiting the amount of food eaten at meals. So some children, if they've got lots of decay, will only eat certain foods. So for example, soft food. So that went from 52% down to 4%. Sleeping problems, we often hear children are awake at night in pain, went from 30% down to 4%. And the most interesting one is behavior. So behavior problems reduced from 32% to 0%. And overall, 90% improvement. So that is compelling evidence why we do need to treat primary teeth that are decayed and not just leave them to fall out, as some might say. And I think one of the most important things we learned recently was from the FICTION trial. So you might be aware of this. It's probably the most important trial that we've had in pediatric dentistry, well, for a long, long time, if not ever. And it was a very, very large NIHR-funded multi-center randomized controlled trial. So lots of different centers within the UK. It was primary care, so general dentists who were recruited. They looked at children between 3 and 7, and they put them into 3 different arms. So one arm had prevention alone, so they had the fluoride, they had fissure sealants, they had fluoridated toothpaste, etc. In the second arm, we had what we called conventional treatment and prevention. So conventional treatment could be anything from giving local and restoring a primary tooth with glass ionomer cement or with composite resin or with a crown. But what you'll see when you look at the study, not that many general dentists use crowns. And then you had the biological with prevention, which are things like preformed crown using the hole technique or indirect pulp therapy. And they compared all 3. And much to the disappointment of us pediatric dentists, who were really hoping that we'd see a huge difference for the conventional arm, there was no significant difference between the 3, which did tell us that we need to push prevention. But it told us something else really important. So when they looked at these children with multiple carious teeth, they said, actually, no matter what you did, 43% experienced pain or infection within a number of years. So when you're seeing 2-year-old children with grossly decayed teeth and parents are saying, well, they're not painful, should we leave them? Or only extract the painful one under GA and leave the others? It's really important to say, actually, we know from studies, almost 50% of children will experience pain or swelling. So again, it's very good to have the statistics behind that when you talk to parents. So looking at the anatomy of primary teeth, because they're different from permanent teeth, and the way we approach them has to be different, and we have to accept that. We know they're much smaller, and they've got a very bulbous crown, and we use this when we place our preformed metal crowns because that's how they stay on. So usually if you're not prepping, you can push it on. They have this big cervical constriction and thinner enamel, which is more porous and less calcified. So you will see decay spreading much more quickly and progressing more quickly in primary teeth. The dentine also is quite permeable, and you have these big pulp horns, especially sometimes the mesial, so that when you have proximal decay, very often we're going to see pulpal inflammation quite early, and you might not in a 6, for example. And the pulp chamber is very large, so when you go in to do your restoration, you are at higher risk of exposing. And a very thin pulpal floor, and what we find when we have an inflamed pulp or a necrotic pulp, we see furcation pathology because you have this thin pulpal floor with big dentinal tubules. We're not looking at the apex like we do in permanent teeth, and we're looking at the furcation. And that's why bite wings are very, very good for showing us pathology in primary teeth, whereas we'd look at a periapical for a 6. So a little bit different. And long curved roots. So the roots, the canals are often very ribbon-like. It can make it difficult for extractions for us. Sometimes we have little fractures. It also makes it difficult if you want to do a pulp therapy, such as a pulpectomy, where you're doing, a root canal treatment, because they're quite difficult to file. And we'll talk about that as we go through. This is from Pulp Fiction, I believe. So a definition of pulp, a soft, moist, shapeless mass of matter. So not very inspiring when we're talking about something that we need to treat. And actually, it's much more than that, because as we see, it's vital. It reacts. It can react to caries. It can react to our treatments. And we've learned so much more about it recently. Pulp Fiction itself is named after the second type of pulp, which are these magazines. characteristically printed on rough, unfinished paper. So if you ever wondered why it was titled as it was, that is why. It's nothing to do with dentistry, I'm afraid. Okay, so looking what we can do. So first of all, if you're looking at a decayed lower E, for example, with a class 2 cavity and you're thinking, it's asymptomatic, what can I do to treat this tooth? And you can always decide, you know, the conventional route. I'll give local anesthetic, place a rubber dam, hopefully, remove the decay, and I'll see if I expose, and if I do, I'll think about that as I go. And that's how a lot of dentists approach children. So first of all, I suppose you could ask about, if you've removed the decay and you haven't exposed the pulp in a lower E, should you place a protective liner? Much like you would in permanent teeth. And it's a very thinly applied liquid on the pulpous surface, and it covers the dentinal tubules, often glass ionomer. The idea being that you prevent sensitivity and that you protect the pulp and it remains vital. Is it a good idea in primary teeth? Well, I suppose as a pediatric dentist, I can never think of a time where I will prep a class 2 cavity and decide to restore it with something like composite or glass ionomer, because I'm always going to be crowning that tooth because it has a better success rate. Could you do it? Well, you can. It's not mentioned in the UK guidance, but it is mentioned in the American guidance for pulp therapy. So just for completeness, I thought I would put it in. Is it very successful, I suppose, is the question, if you do place it? The answer to that is no, actually. And if you look at this study here, it's a systematic review looking at different studies, and it's equivocal. There's really no evidence that placing it or not placing it makes any difference. So it's definitely not something that I ever do. It's not a popular treatment. So, okay, so you've restored the E and you've now exposed. So cariously or maybe iatrogenically. And you're thinking, well, what can I do now in a primary molar? And in a permanent molar, you would usually place a direct pulp cap using something like calcium hydroxide or biodentine or MTA. Can you do the same in primary molars? Technically, you could. It's not a great idea. And as I said to you, primary molars are different. So they're highly cellular. And what we tend to see is internal resorption when we directly pulp cap. You get a lot of inflammation within the pulp. Sometimes you get some calcification and sometimes loss of periapical bone. So it's not a great idea. It is mentioned in the guidance. It's mentioned as not being a great idea. And sometimes papers will recommend that you would only use it if you expose by accident. So if there's a carious exposure, that it's not going to work very well. And the papers will often say as well, you could use it on the occlusal surface of a primary molar, but not really on the axial surface because you're beneath the pulp, and then you'll have inflammation above it. So all in all, doesn't work very well. So is it successful in primary molars? I would say no. I would mention it for completeness, but it's not a great idea. And the Cochrane review tells us this as well. So this is 2018, and they looked at treatment of extensively carious primary molars. And they looked at various things, but they said for direct pulp capping, the number of studies are small, and it limits any interpretation. So really, there's no evidence for placing a direct pulp cap. And as I said to you earlier, do we need to? I would think probably not, because again, if I had a tooth with that level of decay, I would be thinking of either placing a crown using a whole technique, or I'd open it up and do a pulp therapy. And we'll see this as we go through. So as I was saying to you, do we need them? I suppose in a way they're slightly older therapies that we would have used in the past before, you know, the more novel interventions like the whole style crown. So the answer is I would never place a liner or a direct pulp cap nowadays. Because we have the biological techniques, and I'm sure you've all come across these in your universities. Indirect pulp therapy, okay, it's not new. It's been around for a long, long time. The idea with all the biological techniques is that we're sealing off decay. And we've learned a lot about decay recently in that if you seal off the external environment, you can prevent its progression. And if you don't have a pulpily involved tooth, hopefully you can prevent that from happening. So with indirect pulp therapy, you have a deep carious lesion, And classically, you would give local anesthetic, place a rubber dam, and you would clean out as much of the caries as you can, taking care not to expose the pulp, which means you leave some decayed dentine over the pulp. And then on top of that, you place something like calcium hydroxide. Again, you can place bidentine, MTA, Vitribond, or glass ionomers. And the success rate has been found to be very, very high. And these are classic studies. There's Farouk and Vij back in 2000, 2004, and Al Zaire. What you find with those, they compared pulpotomy with indirect pulp therapy, and they found indirect pulp therapy did really well, but they crowned all the teeth they did indirect pulp therapy on, and they didn't crown the teeth with pulpotomy. And they got a success rate of 95%. So it shows us it's about the coronal seal. Yes, you can leave decay in, but you need to seal it well, because if you do an indirect pulp therapy and you push in a zinc oxide eugenol and it doesn't seal it, it's not going to work. So it's about placing a really, really good seal. Mm-hmm. So as I said, our gold standard in pediatrics is the crown. Whether it's a conventional or a whole technique, doesn't really matter. But in this case, you would be placing a crown on top. And that brings me nicely to our preform metal crown using the whole technique, which is really interesting because even when I was a trainee, we didn't believe very much in using the whole technique, because our gold standard was give local, place a rubber dam, prep a tooth for a conventional crown, plus or minus pulpotomy. But we learned over the last number of years, so in around 2005, when it first became popular, it was a technique in Scotland by Mrs. Norna Hall, and she was a general dentist who had a group of children very much like we have here in Manchester, which is very high caries risk. And she knew she should place some crowns, but she felt she wasn't that confident in giving local anesthetic or placing a rubber dam. And she just decided, I'm going to push the crowns on and see what happens without removing any of the tooth. And it worked really well. So that was back in 2005. And we've seen since then, much like indirect pulp therapy, you're sealing off the decay. And if your pulpal diagnosis is correct, your success rate will be close to 100%. So that has been a paradigm shift in our treatment philosophy in pediatrics. And I'm sure every unit are using the whole style technique now. So success rate, more successful than coronal restorations placed by GDPs. So certainly more successful than a glass ionomer, or back when we used amalgam, a composite, because of the coronal seal. And also much, much easier to place and much better for the children. So as I said to you, the major failures in the study was 2%, which meant loss of a tooth or toothache. So that's very, very high success rate. But you have to choose your cases very carefully. And I think sometimes when people say the whole technique doesn't work, they're really placing crowns in teeth that are beyond it. They're too carious, and that's why. So you need a vital pulp. So I tend to crown the teeth that you're picking up on radiograph, classically. The ones that have proximal caries, but you're not seeing furcation pathology, you're not having spontaneous pain or infection. So early to moderate class 2, or even class 1. So occlusal cavities, I have no problem placing whole style crown rather than a composite, for example. Class 1 cavities, important thing, no pulpal involvement, and you need to have been able to take radiographs because you need to make sure that that pulp is vital. So this is a DPT on a bite wing setting. I don't know if you have these in every unit, but it's basically taken in a DPT machine, but it's a bite wing setting, so it's lower radiation and it is diagnostic for caries. Oh yeah, it does work. So for example, if you look at this patient and look at lower left D, and you can see there's a very large cavity, there's not much crown left, and there's actually furcation pathology. So for that tooth, I'm thinking, actually, I'm going to need to extract it because there's no crown left for me to, even if I did a pulp therapy, there is nothing for me to restore. But for example, if you look at the upper right D and E, so upper right D has distal caries and E has mesial, but it's not advanced and there's no sign of furcation pathology. So I'm thinking for both of those, well, I could place something like a preform metal crown using the whole technique, and that would be very, very successful. Lower right E, I'm thinking that tooth extensively carious. It's likely to be pulpally involved. Probably, if I'm going to save it, I'm going to need to do root treatment, like a pulpectomy. And lower left E, again, you've got extensive occlusal caries. There's no sign of furcation pathology. So if the tooth is asymptomatic, it might be that I would do pulp therapy because it's extensive. So it depends very much on the tooth, and you might do different therapies on different teeth in the same patient. So when not to use a crown, as I said to you, that's the main issue with whole style crowns, so teeth that are beyond it. If you see furcation pathology, pulpal involvement, bearing in mind that pulpal exposure will precede the radiographic signs. So it's more advanced than it looks radiographically. A tooth is unrestorable, so no matter what pulp therapy you do, if you can't restore the tooth afterwards, there's no point in doing that. If a tooth is close to exfoliation, so if it's going to exfoliate in the next 6 months or a year, is there any point in restoring it? If it's going to endanger the patient's airway, so if a patient isn't cooperative, crowns are a little bit slippery, so you might avoid that. If they've got congenital heart disease and there's increased risk of infective endocarditis, you will err on the side of caution and extract the tooth. Nickel allergy, so that's a contraindication to a preformed metal crown, or if parents or patients don't like crowns, but it's quite uncommon that that happens. So look at the studies, what do parents and children think? So children universally prefer whole style crowns to conventional restoration, mostly because they're not having local anesthetic. Parents prefer them for the same reason. They think they're easier for their children. And dentists prefer them because they're easier to place and because they're not giving local anesthetic. And that's a major source of anxiety for dentists, so giving local anesthetic to children. So all in all, very, very good technique. And this was a paper by Richard Welbury looking at the whole technique 10 years on, and concluded whole crowns, there are benefit to children and there are no harmful effects. So why not? So biological techniques, are they successful? Absolutely, yes. Very, very successful and very, very easy to do. So that brings me on to pulpotomy. So a technique which involves removing the coronal pulp, which is irreversibly inflamed, and you maintain the radicular pulp, which is either irreversibly inflamed or non-inflamed. And what's the difference between that and a whole style crown? Well, it's the extent of the decay. So if you have decay that's radiographically pulpily involved, or you've had a tooth that it's been painful, on eating something sweet and the pain goes away, so it shows a reversible pulpitis. We know from studies, and I'll show you now, that the pulp horn, so this is a study by Professor Dugal and New back in Leeds. They looked at primary molars with proximal caries, and they looked at the extent of caries versus inflammation in the pulp. And as I said to you before, what they found was the inflammation in the pulp in primary molars would precede its exposure, which is why you have a lot of people who restore primary molars conventionally and say, well, I removed all the caries, I restored it with composite, and it became infected. And that's because you can remove all the caries, but before the caries reaches the pulp, you've got pulpal inflammation. Oh, we know this, and we need to take it into account, and particularly in the big pulp horn closest to the carious attack. And what happens with that? You get rapid inflammation of the coronal pulp. And what this study showed us, in primary molars with extensive proximal caries, so more than half the intercuspal width, we need to remove the coronal pulp, but the radicular pulp is not inflamed. So we can remove just the coronal pulp, leave the radicular, and it would be vital. So that's the idea, that we leave vital pulp in the tooth. So that's pulpotomy. It's vital. Pulpotomies are always vital. There's no other type. And what do? You've got decay exposing the pulp chamber, and basically you give local, you place a rubber dam, and you just remove the pulp in the pulp chamber. That's it. Then you should have a vital radicular pulp. And if you do, you put something on it to stop the bleeding, you fill the pulp chamber. You can do it with ferric sulfate, that's probably what most of you do. You can place MTA. I use most of mine with MTA at the moment, or you can use Biodentine if you want to. And the success rate is very, very high, so long as you crown the tooth afterwards, and as long as you get your pulpal diagnosis right. So you're not doing it when you've had spontaneous pain, or infection, or sinus, or furcation pathology. So it's vital. And as I have said here, success rate between 92 and 96%. So very, very high success rate. I've mentioned pulpectomy. It's unlikely you'll do them. I do very few, to be honest, but pulpectomy is when you've got a non-vital primary molar and it's just root canal treatment. So it's more difficult. And as I said to you earlier, the canals are very ribbon-like. You need a child who's cooperative enough to allow you to take a periapical radiograph of their E or their D, and there are very few children who will allow you to do that. You will file up to about size 30, and you're taking care not to go through the apex. So you stay about 2 millimeters back, because the other difference with primary molars is you've got a premolar underneath that you don't want to damage. Then you need to irrigate and clean the canals, fill it with something that will resorb, like Vitapex, and again place a crown. And success rates, they're about 80%, but they're 80% done by specialists who do them all the time in cooperative children. And certainly if you have a child who's very high caries risk, I would be more inclined to extract more teeth than do multiple pulpectomies, because you're unlikely to get the cooperation for that. But you might do one if you have somebody who's very low caries risk, and for example, they've got one hypomineralized molar and they've got an intact arch and you want to maintain it. Or they've got hypodontia and you really want to maintain that E because they're missing the 5 underneath. But it's rare. I've only done about 2 in the last 2 years. So for pulpotomy, and as I said, pulpotomy, always vital. Indications, so large decayed lesion, plus or minus pulp exposure. So really, you're looking at greater than half intercuspal distance, because we know from our study that that means the pulp is inflamed. You need a vital pulp, so it needs to be bright red and it needs to bleed, but it needs to stop bleeding quite easily, so within 5 minutes. You need more than 2/3 of the root remaining, so if the tooth is close to exfoliation, you're not going to do a pulpotomy. No sign of infection or abscess, no furcation pathology, and no spontaneous pain. Contraindications, as I said before, at-risk patients and cardiac patients will be contraindication. If you don't have enough teeth left to restore, that's another contraindication. Extensive resorption, or greater than 3 teeth. So like I said, with the extensively carious teeth, I'm more likely to extract than I am to do pulpectomies or pulpotomies and multiple teeth. If it's close to exfoliation, or if you have those kids who come with big facial swelling and we need to admit them to hospital, again, we'd be thinking of extracting those molars rather than restoring, because the risk is too high. The medicaments you can use, so the most common one is ferric sulfate, which is just astringent, and it will just promote hemostasis. And success rate, I mean, it's up to 100%, so it's pretty good. MTA, I'm sure you're all familiar with MTA. It's new material. That's what it's made from. It's bioactive, so you get cytokine release and you'll get hard tissue formation in the pulp. So very similar to how you do a normal pulpotomy, but rather than dressing with zinc oxide eugenol or anything like that, I just pack it with MTA. And success rate is close to 100%. So either of those, absolutely fine. So you've probably heard about formocresol in the past. Is formocresol an appropriate medicament for pulp therapy? And when I was training, it was, when we used to use it, and it's really good because it fixed the pulp, and even if you got your diagnosis wrong, it still worked. However, nowadays we don't use it, so that's Pulp Fiction. Why? There's a very famous study actually that promoted people to stop using formocresol, and it was one done in dogs. So it was done by Myers in '83, and he took 5 mongrel dogs and they all got a GA, and dog 1 got 16 formocresol pulpotomies. Now, bearing in mind, these were quite small dogs. Dog 2 got 4 formocresol pulpotomies. Dog 3 got only 1. Dog 4, he was the unfortunate one. He got 16 pulpotomies, but no formocresol because he was the pulpotomy control. And then dog 5, he did even worse. He just got a GA because he was the GA control. And then, unfortunately, after a number of hours under GA, they were all euthanized and their livers and kidneys were assessed. And what did they find from that? Well, in dog 1, who had 16 formocresol pulpotomies, he had some changes to liver and kidney, which I suppose is not unexpected if you've done 16 pulpotomies in a very small dog. And you'd never do 16 pulpotomies in a child. However, it gave cause for concern, and the International Agency for Research in Cancer classified formocresol as carcinogenic in 2004. So it's associated with nasopharyngeal carcinoma. And that is why That technique is dead at the moment, and we don't use that anymore. So how do you do a pulpotomy? Well, as I said to you, you need radiographs. And these, so if you look at the upper right, D and E, so you've got extensive distal caries in the D and mesial on the E, but you don't have any furcation pathology. So if these teeth have been, if they have symptoms of reversible pulpitis, I wouldn't be thinking of placing a whole style crown, I would be thinking of doing a pulpotomy. However, this one, you've got extensive caries, you've got furcation pathology, that I'm thinking of extracting, because there isn't even much tooth to restore. So you always give local, place a rubber dam, and I tend to prep the tooth for the crown as I go, and then you remove the pulp chamber and you excavate out the coronal pulp. And if you can see there, it's quite hard to see, but you should see the pulp canals, just the kind of red openings, and they should stop bleeding quite easily. So if you're placing ferric sulfate, you can put it in your dappens pot or burnish it with a microbrush just for 15 seconds, or a little bit of cotton wool in the chamber for 15 seconds, and that should achieve hemostasis quite easily. If the pulp continues to bleed, it's hyperemic, so it's inflamed, so you need to probably take away more or decide not to do a pulpotomy, or if it's not bleeding at all, it's necrotic and you need to do a pulpectomy or extract. Then once you've done that, you pack the cavity. You can place zinc oxide eugenol if you've used ferric sulfate, or you can just place MTA, which is what I do, and it just covers it quite nicely. You can see the white there. And then you place your crown on top, because the coronal seal makes all the difference. And that should be just fine. It should just exfoliate as normal with the tooth. So it's our gold standard restoration, preform metal crown. So here you can see it's going on over a pulpotomy, and you can see the pulpotomy, and ideally the medicament will push down into the canals a little bit like that. So that looks really good. And all these studies have looked at preform metal crowns and they found an increased success rate. So no matter what you're comparing it to, preform metal crown performs better in children. So we've talked about the biological technique. It works really well. So is there still a role for a pulpotomy and conventional crown? Well, there is, because it depends on the pulp. So if you've got a pulpily involved tooth, then you're going to need to do pulpotomy. By definition, you need to give local anesthetic and place a rubber dam for that. So if I'm doing a pulpotomy, then I'm going to place a conventional crown rather than a whole style, because whole style, you're not removing caries. So they're different. So yes, I think there's a role for both, and they're both very, very successful. I'm almost afraid to use the term non-vital pulpotomy. However, I'm asked about it all the time. As I said to you before, if you're doing a pulpotomy, it's vital. If you're not, you're doing a pulpectomy and you're doing a root treatment. There's no such thing as a non-vital pulpotomy. No, it doesn't exist. So you can forget about that. I know that's quite confusing. So we've touched on this, but the important thing for, medical history, is pulp therapy appropriate for children with congenital heart defects? Well, for most of these children, if they're at increased risk of infective endocarditis, and that does depend on their heart defect, this one here, tetralogy fallow, certainly there will be at lifelong increased risk of infective endocarditis. We do not do pulp therapy in these children. Even though it's very successful, the risk of getting infective endocarditis is relatively high. And if they get it, their mortality is 30%. So I would much prefer to extract the tooth, and then the risk is 0. So we don't take any chances with these kids. What about hemophiliacs? They're the classic group, actually, where we like doing pulp therapy, because we want to create less bleeding in these kids. So we want to avoid extracting teeth if we can. So classically, the hemophiliacs are the ones where we like doing pulp therapy and crowns. So they're primary molars. And then moving on to the immature permanent molar. First of all, you have the uncomplicated crown fracture. And what do you do with that? Well, you need to cover it. You need to cover the dentine, and you need to restore it. And I'm often quoting this study by Raven in 81, because he said these teeth have an excellent prognosis of remaining vital as long as you cover the dentine. So if you cover the dentine, 92% will stay alive. And particularly for an immature tooth, you desperately want it to stay alive so you get continued root growth. If you don't cover it, you have an over 50% chance of that tooth losing vitality. And then your issue is it's a complicated endo technique. So if you can even cover a glass ionomer and then later a composite, that's absolutely fine. But ideally, something like this where you have dentine, just cover it straight away. If you don't, this is what you can see. So you can see both upper ones here have uncomplicated enamel dentine fractures. And they weren't covered. An upper left one is now non-vital. So draining sinus, you can see the big area here. And you know, they have such a good success rate, you could easily avoid that. Complicated enamel dentine fracture, now that's what confuses people sometimes. So it's involving the pulp and you've got to do some sort of pulp therapy. You've got to decide what you're going to do. And it depends on how big the exposure is. Often the studies will say it depends on whether or not you've got a mature or immature incisor, but it doesn't really. I mean, you can still go ahead and do the same pulp therapy. So direct pulp capping. Can you still hear me?
Yes,
yeah,
we've got you. We're back again.
Sorry, I think that's my internet. There we are. Can you see me?
Yeah, I don't think we got the last slide. We didn't.
Yeah.
The last slide.
Yeah, maybe like halfway through it.
This one.
Yeah.
Yeah.
Okay, I start on this one. So talking about complicated enamel dentine fractures involving the pulp, you're going to have to do some sort of pulp therapy, no matter what that's going to be. And if you look at the studies, they would say, well, it depends on whether it's a pinpoint exposure or larger, or whether or not you have a mature or immature permanent tooth. And it doesn't really, I mean, from my point of view, I tend to use the same therapies, whether it's an immature or permanent tooth or mature tooth. And looking at direct pulp capping, so the books will tell you when you have a pinpoint exposure, you can directly pulp cap it and then restore the tooth. And this is Anna Fuchs, and this is the name you'll see in lots of papers when you look at direct pulp capping. And she looked at 38 teeth, all had pinpoint exposures. Now, bear in mind, a pinpoint exposure is so tiny you could almost not see it. So teeny tiny. They had completed root development, and she placed a direct pulp cap with calcium hydroxide. So just placed setting or non-setting calcium hydroxide and restore the tooth. And she said success rate 81.5%. So it's quite high. But you've got a 20% risk of your tooth becoming non-vital, which we don't want. And I'm sure you're all familiar with Schweck Pulpotomy. So this is Maimir Schweck. And I think he only passed away in around 2008. So it's not that long back. And he decided that in the past, when there was a complicated enamel dentine fracture, dentists used to go in and just take out the pulp. So they'd extirpate and do a root treatment. And he thought, well, maybe we can just take away some of the pulp and maintain vitality in the rest. So he looked at 60 permanent incisors, and more of these teeth were mature than immature. So 32 were mature, 28 were immature. So when people tell you you need an immature tooth to do a Schweck, you don't. It'll work on both. His size, so the size of the exposure it varied between 0.5 to 4 millimeters, and it was over a long period of time. So 1 to 2 to 160 hours. And he found a success rate with calcium hydroxide of 96%. Now, what was the difference, rather than a direct pulp cap with Anna Fuchs, was that he was taking away a couple of millimeters of inflamed pulp, giving him a little cavity to push the calcium hydroxide into. And that's really the only difference between them. And this is how you do a Schweck pulpotomy, and this has been done by one of our undergraduate students. So you give local anesthetic, place a rubber dam, and this is an anterior dry dam. I don't know if you're familiar with it, but it has little hooks that hook around the ears and stays in place, so you don't need a clamp. You open up the exposure, and can you see here, he's taken away about 2 millimeters of inflamed pulp. And you can see there's a little cavity, and there's a red pulp in there that stopped bleeding nicely. So it's a healthy pulp that's left. Then he's placing calcium hydroxide into that cavity, packed it in, and then restore the tooth, and it looks really good. And success rate is high, and what you want to see is continued root development after that, if you've got an immature tooth. The other thing you'll see is pulp canal obliteration. So this is what it looks like. So if you look here, 2 days post-trauma, upper left one, you've got this immature one with a wide open apex. And you can imagine if that loses vitality now, it's going to be very weak. So did a Schweck pulpotomy in 3 years, you've got continued root development and you've got a closed apex. So that tooth is likely now to last the patient's lifetime, which is amazing. For such a simple treatment, it's amazing. And as I said, they're prone to canal obliteration, so don't be surprised if the patient comes back and they don't test positive to sensibility testing. It's not because they're non-vital, for the most part, it's because they've obliterated, which is a sign of vitality. And the other thing that does is cause them to look a little bit yellow in colour. So that's absolutely fine. And success rate, 96%. Then we talk about full coronal pulpotomy, and that is really just, you're doing a Schweck, you're taking away 2 millimeters of pulp, the pulp is still inflamed, you take away a little bit more until you take away the coronal pulp. And then you do exactly the same. Place your dressing, restore the tooth. And you see this if the exposure is a little bit older and the pulp is more inflamed. So that's the only difference. But of course, because you've taken away more pulp, your success rate will be slightly lower with that. And you can see here, upper right one, this tooth had a complicated enamel dentine fracture. And one of our specialty dentists started to do a Schweck, found it was inflamed, continued. When he removed all the coronal pulp, he found that the radicular pulp was healthy. So this is actually by dentine, it's placed by dentine and restore the tooth. And it was just fine afterwards. And it's an open apex, so we're hoping to see this continued root development over the next few months. So vital pulp therapy in immature permanent incisors is successful. Yeah, it is. It's very successful and it's very easy to do. And there's no reason we wouldn't. What about non-vital? So try as we might, sometimes these permanent incisors, patients come to see us and they're non-vital. And we're left with this very immature tooth. And you can see you've got a very short root and you've got very little dentine. So it's a weak tooth as well. So what do we do with that? And how do we do a root treatment? Because we don't have a stop at the apex to actually push the GP against. So it's a little bit challenging. And considering the fact you're doing this often in someone who's 7 or 8, who's not too keen to sit still for very long. So I suppose it depends on why the tooth has lost vitality. For us, a lot of it is due to caries. So here we have the percentage of children with obvious decay by age. So at 8 years old, in 2003, decay into dentine, 50%. So, and we do see lots of children, particularly the teenagers, with non-vital upper ones because of decay, unfortunately. Dentoalveolar trauma, very common. So complicated enamel dentine fracture. This is just showing us in all different countries. Percentage of children with accidental damage to incisors. So 15 years in England, 26%. That was 1983. You come to 2003, 13%. So it's quite a high percentage of children. You can see there, and 8-year-old is 5%. And the other time you can have a non-vital anterior or premolar would be a dens invaginatus, so a tooth within a tooth where it's become inflamed and it's non-vital, or a dens evaginatus, tends to be in premolars where you have an outpouching of the pulp into a little enamel pearl and it tends to shear off and it exposes the pulp. And it can often leave us with a very immature premolar that we need to do a root treatment on. Not easy. So what are the challenges of the open apex? Well, we need to disinfect the tooth, but we don't want to file it very much because we've little enough dentin as it is. So we're trying very hard not to do that. We're just trying to extirpate and just irrigate the tooth. How are we going to fill it? So as I said, there's no barrier at the apex. So quite often when you look, you've got this big wide apex and you put your file in and it goes right through. So, and you can't feel anything at the apex. So we've got to do something about that. And long term, we know these teeth, because they're weak, they're susceptible to fracture. And you'll see as we go through the presentation, in the past, the way we used to achieve root enclosure, a lot of the teeth would just fracture off. The crown would fracture off a couple of years later. So that's an issue as well. So what do we want to do? Well, we want to close the root end. That's number one. Ideally, we would love if we could get an increase in root length and an increase in dentinal wall thickness. But that's a big ask for these teeth. So when I was a trainee, we used to do something called calcium hydroxide apexification. So apexification means that we're inducing a barrier artificially at the apex so that we can do a root treatment. So this was really old. It was introduced in the 1960s. And what did they do? Well, you took a tooth, so that's an incisor, there's the pulp, and it's got an open apex and it's non-vital. So you open it and you extirpate the pulp, and you don't file because you've little tooth left. Wash the tooth out with sodium hypochlorite as you would a normal root canal. Dry the tooth with a paper point. And then we used to place calcium hydroxide, so either spinning it in, or nowadays we just inject it into the canal and push it down with a moist cotton pledget, and then put glass ionomer on top. And the calcium hydroxide would stay in contact with the apical tissues, and over time created a barrier. That was the idea. But you had to do it very often, so about every 3 months for about 18 months. So it was a huge amount of time out of work and out of school for children and parents to come to see us. And how did it work? Well, it's got a very high pH. So calcium hydroxide is very alkaline, and it's very good for killing off bacteria. So bactericidal, and you get this liquefaction and coagulation necrosis adjacent to the healthy apical tissues. So you get this like cementum-like structure. So you get a barrier, and you can just see it there over time. However, there were some issues with this. So the more often you replace the calcium hydroxide, the faster you got your barrier, which, okay, that's fine, but it's a lot of visits for children. It depends on the apical width. So you have a big wide open apex, it takes a lot longer. It depends on the severity of the trauma. So the more severe the trauma, the longer it took for a barrier to appear, because you had lots of cells that died off. Or if there's an abscess or periapical radiolucency, again, it took a bit longer. So average about 9 months, which is quite big. The other problem with the barrier, it wasn't a great barrier. So it was a bit like Swiss cheese. There were holes in it, and then you could have bacteria leaking through. And the other problem, it didn't always form at the apex where we wanted it. It formed wherever it felt like itself. So occasionally the patient would come back and they would have a barrier halfway down the root. And you're worse off than ever when that happens. And the other issue with calcium hydroxide was that it weakened the tooth. So here Schweck, he's probably the most commonly quoted in this retrospective study. And he looked at immature teeth. So this one, upper left one, has a wide open apex. That's 2005. It's been dressed for a year with calcium hydroxide. And then 2006, you got apical closure, you got a barrier, but the crown is fractured off. And that's what we found quite a bit. We treat these children for maybe 2 years. They'd have come every 3 months. Finally, we've an apical barrier. We've root treated it. They bite into an apple and they've got the crown in their hand, because it denatures the dentine and it reduces the hardness and the modulus elasticity of dentine. And here's a graph from his paper. So here, percentage of stage of root development and number of fractures in percent. So the less mature teeth had a much higher percentage of fractures. So that just showed us wide open apex, you had very little dentine to start with, then you place calcium hydroxide, it weakens it, and they tend to fracture. So these are the studies, which might be useful for you for your exams. So Andresen, 2002, the fracture strength of calcium hydroxide filled in immature teeth would be halved in a year due to root filling. Rosenberg, again, very similar, you weakening the dentine by up to 43.9% with calcium hydroxide. And Wadji Twati, I actually trained with him in Leeds, and he took premolar teeth extracted for ortho and cut them in half. And on one side, he put sodium hypochlorite, and on the other, he put non-setting calcium hydroxide. And he checked them after 3 months and 6 months, and he found the non-setting calcium hydroxide had dramatically reduced the strength of the tooth, of the dentine. So basically, it denatured the protein in the dentine. So the conclusion, unreliable evidence supporting the use of calcium hydroxide. And we've stopped using it now. We don't use it any longer for apexification because of the reduction in fracture strength. So it's no longer recommended. So if that's the case, what can we use? Because we still need to form an apical barrier, no matter what way we go about it. So we use MTA, and this is what we tend to use in our department at the moment. And how do you do it? Well, it's actually much easier than calcium hydroxide. The first steps are the same. You're taking the pulp out of the tooth, you're irrigating it, and you are drying it. And then you're placing a little plug of MTA, which is a cement, just at the apex, and that forms your apexification. And you use these little pluggers to do it. So it's like a straight amalgam carrier. Then you obturate the tooth using a warm vertical condensation, so an obtura, something like this, and then just place plastoionomer or composite. So it's one step. So you don't have all these visits for the patient. Advantages of MTA, well, reduced number of visits. It's biocompatible, so it's very, very easy to use. You will get induction of odontoblasts, so you get this hard tissue barrier. It would set in a moist environment, so classically we will seal a moist pledged cotton wool into the canal to let it set, and then bring them back for another visit for obturation. It's radiopaque, you can see it really well in X-ray. It's not soluble, and again, much like calcium hydroxide, it's got a high pH. The main disadvantage is discoloration. So you need to be quite careful to keep it away from the coronal aspect of the tooth. And it discolors because it has bismuth oxide. Even the white MTA, so it comes in white and grey, even the white will discolor teeth, unfortunately. It's expensive and you can't dissolve it. But you can wash it out before it sets if needs be. And setting time is quite long. But success rate's really high. So here we see upper left one, and this is nicely placed MTA. And the studies show it's about 90% when you do it well. And then you have to use warm vertical condensation. So once you place your MTA, you have warm obtura that you pack in. And you can use it even if you don't have an open apex, you can just use obtura to obturate a mature tooth as well. And again, in our department, I very rarely use cold lateral condensation. It's almost always warm vertical. It looks very nice in radiographs too. So MTA, unfortunately though, we looked at the literature and we thought, is this, the holy grail of apexification? No, apart from the discoloration, it also contributes to increased brittleness of dentine. Again, that was Wajdi Tashi, it was unpublished work, but he said it might be as bad as calcium hydroxide because it also makes the dentine weaker. So is it successful in the long term? Well, it's what we have at the moment. It works pretty well, but is there a better option? There wasn't, we thought, for a while, but quite recently we've come across what we think is a better option, and we're all delighted about it. And of course, it's biodentine. So it's a calcium silicate-based cement, sets in 12 minutes. The problem with it is you have to place it and you have to just leave it for 12 minutes and sit there doing nothing. Because if you touch it, it liquefies again. But 12 minutes is faster than MTA, doesn't cost as much. Handling properties, I suppose it's a little bit like a zinc oxide eugenol in its handling, whereas MTA is a bit like wet sand. So they're quite different, so you've got to get used to it. It's got a high strength, but it's not as radiopaque. So if you see here, upper right one, we have filled that canal with biodentine, but it's not as easy to see as the MTA in the previous radiograph I showed you. So that's one of the downsides. You can't tell as easily on radiograph, but it works really, really well. So success rate between 90 and 100%. So that's apexification, but are there any other options? Now, particularly if you've got a very immature tooth, a big wide open apex, and you're thinking, if I do apexification, the tooth still isn't going to last because the crown root ratio is too low. So, the 7-year-old two-way volts is a 1, and you put it back. So you could also try regenerative endodontic therapy. And I'm sure a lot of you will have come across this. It's not new, it's been around since the 1960s. And the aim is to try to promote continued root development, so that the root to grow. As it grows, you get thicker dentinal walls, so you get a much stronger tooth, and that will improve the long-term prognosis. And that's the idea. What do you need? Well, what do we want? We want pulp, ideally. Pulp in the canal. If you've got pulp that's vital, then you'll get continued root development. If you don't, you won't. So what do we need for that? Well, we knew we needed stem cells from somewhere to form pulp. And, well, you can get them from loads of different places, actually. In the mouth, But the ones we tend to use for regenerative endo are the scap cells, stem cells of the apical papilla. So the ones that are through the apex, you're trying to bring them into the canal to form a new pulp. And if you do that, you need some sort of a scaffold to keep everything in place. And that could be a blood clot, and that's what we tend to use quite often, which will just hold the stem cells. Or you could sometimes, in some studies, they inject something into the canal like a hydrogel. Protocols differ a little bit that way. But you need a scaffold, and you need some sort of signaling molecule as well to get everything to transform into pulp or pulp-like tissue. And where do you get signaling molecules? Well, they're in the teeth already. And the idea is they'll cause induction of cellular proliferation and hopefully into pulp. So you've got different types, growth factors, transforming growth factor beta, human insulin-like growth factor 1. It's normally in the dentine. So you get that by irrigating with EDTA as you do your root treatment. And in all of that, you need it to be sterile. So if it's not sterile, you're not going to get any form of regeneration. So how do you do it? Well, at your first appointment, you give local, take the pulp out, so extirpate it, irrigate with saline and dress. So far, so like calcium hydroxide and MTA. But you want to make it sterile. So what we tend to do is place some antibiotics into the canal. So classically 3 antibiotics, metronidazole, ciprofloxacin, and minocycline. Now the problem with minocycline, it causes staining. And it causes the teeth to stain a very, very like horrible, like dark, yellowy grey colour. So a lot of protocols now leave that out and still get the same results without the discoloration. So leave that out. You can use something like this, like a little cannula to inject into the tooth. But you fill the canal with this paste of antibiotics. And then you put a cotton wool roll and you seal it off with a glass ionomer, and the patient goes away for a week or so. And hopefully during that time, the canal becomes sterile. So then they come back in a month and you open the tooth and you've got the antibiotic in there. You irrigate it with saline. And as I said to you, EDTA, because you want to release the growth factors as well. Dry. And then you induce a blood clot into the tooth from the apex. So that brings the scaffold and that brings the stem cells from the apical papilla. We say to use plain local, that is because we want to induce bleeding. And if you use a local with adrenaline, it will just reduce your chances of getting a blood clot. So plain lignocaine. And then you can just place, we tend to place MTA or Portland cement, glass ionomer, and then composite. And then you wait and you watch and you see if you get any sort of continued root development. So here's one case we did when I worked in Leeds. So upper right 2, non-vital, wide open canal, and here we've induced the clot, we've placed a barrier, and we're waiting. You can see here 9 months afterwards, you see there's actually quite a large increase in root length, and you can imagine as this continues to grow, you'll see apical closure. I mean, it's certainly a lot narrower than it was initially, and that's a much stronger tooth. Even if it lost vitality now, you'd be in a much better position. So that's worked quite well. And this is another example. So pre-op, upper 1s, so upper right 1, non-vital. Immediately post-op, so this is, I mean, it's very hard to see, but you've got the blood clot in the canal and you've got your Portland cement, and it's closed off. Yeah, and after 12 months, you can see there wasn't a huge increase in length of root, but actually it's closed over. And it's asymptomatic, and it's in place, and it looks aesthetic, and it's a good result for the patient. So looking at the evidence, it's quite difficult. With regenerative endo, most studies, like a lot in dentistry, they're not very high quality. And what they showed us, it's very good for maintaining the tooth in a long-term state of non-infectiveness. So it's good for that, and it's good to maintain the tooth. As I said to you, the tooth is there, it's not infected, it's maintaining the space, it's maintaining the aesthetics. Are you seeing a huge increase in root development or apical closure? You did in some cases, and all the protocols are slightly different. And in some studies, you'll notice they measured the increase in root development and increase in dentinal thickness using computer software. And you could argue, if you need to do that and you can't see it clinically, does it actually make any difference? And I think probably not, to be honest. And if you're using MTA, you need to be careful, because you can get this, I said to you, it's really horrible discoloration, actually, really, really dark grey, that patients don't like. The other question we had in the past was, does the etiology of pulpal necrosis affect outcomes? And as I said to you at the start, you've different reasons for loss of vitality. So you've got plain caries, you've got trauma, and you've got dens and dentae. So this is a dens and dentae we extracted. You see this big communication to the periodontal ligament. And the idea was that trauma was less likely to be successful because you damaged the epithelial root sheath that you needed for continued root development. But this is a systematic review looking at that very question. And it said actually there was no difference recently between different etiologies of loss of vitality and the outcomes for regenerative endo. So that's good to know. We can actually use it for all of these teeth. So there's no difference.
I think we should be leaving now. Yeah, that's probably a good idea.
So that's just a brief overview of pulp therapy, but I'm happy to take any questions that you might have.
Thank you. I think we've got one question on the chat. I've been sent some. Suppose that.
Yeah. There we go.
My internet. Yeah, sorry.
Hello.
The question, it was, when placing a medicament during a pulpotomy, would you usually use saline first or go straight to ferric sulfate?
I tend to go straight to ferric sulfate if I'm using ferric sulfate for the pulpotomy, because that will stop the bleeding. If you think about it, you don't even need ferric sulfate. You could even just use a cotton pledget with saline or sterile water and just put pressure on the pulp, and as long as it stops bleeding, you've got a healthy radicular pulp, and you can just go ahead and place whatever dressing you're going to place. But if ferric sulfate is what you're using, you can just go ahead and do that straight away.
The VAST after that, do you find that ferric sulfate can mask the bleeding from the inflamed radicular pulp? Yeah,
and that's one of the criticisms of ferric sulfate, really, in that if you've got your diagnosis slightly wrong, it could mask it. Not as much as former Cresol used to. That's why nowadays I use sterile water and just a cotton pledget, and once I see hemostasis, then I put in MTA.
So do you use sterile water before ferric sulfate? Or?
Well, I don't use ferric sulfate. They're two different treatments.
Oh, okay.
Ferric sulfate will stop bleeding, and then people tend to put something like a zinc oxide eugenol in the pulp chamber. But when I'm using MTA, I just use sterile water. I mean, the answer is a healthy pulp should stop bleeding very easily with just pressure. So you can use either.
Okay, thank you. And then also been asked, what prevents the MTA from going beyond the apex? I think that's when you were talking about the immature apex.
Yeah, I mean, that, I suppose experience is what prevents it. It doesn't really, I mean, some people when they start, they do go through the apex. And if you do, it's biocompatible. So actually, it doesn't make a big difference. But we're very careful when we place it that we have our MTA carriers shorter than the apex, so we measure everything so that when we place it, it's a couple of millimeters short, and then our packer is a couple of millimeters short. So as we place it, first of all, you don't feel anything with the packer, and then over time you start to feel it like wet sand, and you push very lightly. So you filled a couple of millimeters before your packer touches it. So if you get your measurements right, that works really well. But
Yeah,
you're right,
that makes sense.
it's tricky. It's a tricky thing to do.
And how can you tell if the radicular pulp is healthy?
But because you're looking at it, so a healthy pulp will be bright red, it will bleed, but it will stop bleeding easily. So if it's bleeding and it won't stop easily, then it's hyperemic, so it's inflamed. And if it's not bleeding, it's necrotic. So that is very visual.
Yeah. Somebody's asked, what is the best way to go about mentioning this lecture in a dental personal statement and dental school interviews? That might go for me and Owen.
But I suppose are they coming to Manchester? Have you told them I'm admissions tutor for Manchester? So might be coincidence. You could just say it's part of the extracurricular interest you have that you come to these extra lectures, and it's more about what you got from it, I suppose, that you came to the lecture and that you learned something and reflecting on what you learned.
If you are from Manchester, then you can get the posters from the Society app and print those out, and all the other webinars you've been to.
Yeah.
Some of them offer like CPD hour certificates. We can't do that yet because we can't have you all in person, but maybe later we can.
Yeah.
Future plans.
Another one is, what is the difference between biosilicate and bioaggregate, and can the latter be used for apexification?
I have no idea. That's one for a material scientist, I'm afraid.
What are the best LA techniques for children?
It's all about how you introduce it. So make sure you use topical anesthetic. Always use a short needle. I tend to use Articaine, which is very, very good because it's 4%. You can use the wand if you want to, if you've got a particularly anxious child. And if, all your behavior management techniques, your tell to do, your distraction, counting, all of those. It's a little bit of everything.
When removing the coronal pulp, can the radicular pulp become infected?
No, not usually. If it's not already infected, it won't, because you're putting something on it to create a barrier then. So if you've got your diagnosis right, no, it won't.
This is a good one. Is staining from MTA reversible?
It's very difficult, actually, to reverse it. We do sometimes try bleaching, and that can have a certain effect, but it's quite tricky. Yeah, it's very hard to mask the staining of MTA, which is why I think bidentin is better now.
Yeah, is the other two not used anymore now that bidentin is available? But
MTA is used probably most frequently because it's the one that most people have. I mean, bidentin is relatively new, and you need to get used to the handling properties, which are slightly different from MTA. MTA, if you were using it for a molar, primary molar, it doesn't matter about discoloration, you're crowning it. If you're using for apexification, we take it to the apex and we make sure that we clean the tooth really well and keep it away from the coronal part, so you don't get much staining. What I wouldn't use MTA for would be a Schwedt pulpotomy, where you place it in the coronal pulp, because that's when you're going to get lots of staining.
Yeah, that makes sense.
Yeah.
Could you explain again why infection is less likely to spread from coronal pulp to radicular pulp in primary teeth versus permanent teeth?
Well, it's not that it's less likely to spread, but what we're saying is you're more likely to get early pulpal involvement in primary teeth. So we know when you have a carious challenge, even if the pulp isn't exposed cariously, that the coronal pulp is inflamed. And we know that from the histology studies, which tells us when you have a carious lesion over half the intercuspal width, a breakdown, the coronal pulp would be involved, which is why we do a pulpotomy. Obviously, if it's more advanced and the tooth is non-vital, then the whole pulp will be involved. So it's all about, it's just stages.
Best treatment option for a young 5-year-old child with apical symptoms such as a buccal sinus if parents aren't keen on an extraction?
You're very stuck there, because if you have a 5-year-old, I think it's very, very unlikely. Well, it depends on a lot of things, but it's unlikely they'll allow you to take a periapical radiograph, give local, and do a pulpectomy. Just from a cooperation point of view. If there are other decayed teeth, the most likely option for that child would be a general anaesthetic and extraction of those decayed teeth. I would be saying to them, being honest, you know, it's just going to be too much to ask of them to do that. It's too much to ask of a 5-year-old to do a full root canal treatment, particularly more than one tooth when they're awake. And most children just wouldn't manage it. So the best treatment and the most routine one that I do is extraction at that age.
Yeah.
Yeah.
What makes the Vitapex resorbable different to Gutperga?
So Vitapex is just calcium hydroxide with iodoform. So it's resorbable. It's just like a cream. So it will resorb, and even if it goes through the apex, it will disappear. And it's like when you're doing endo and permanent tooth, if calcium hydroxide, if you see a little puff through the apex, and then after a few months it's gone, because it just resorbs. Which is why when we did calcium hydroxide apexification, we had to replace it every 3 months, remember? Because it wouldn't last any longer. GP won't resorb, it's inert. It's like a rubbery material. So you couldn't put that in a primary molar. Yeah, they're just completely different.
We had a question of what's the reason of using that material over the Gutperga?
Of which?
The Vitapex resorbable.
Because it resorbs, because remember, primary molars have to resorb. Physiologically, they have to resorb, so they exfoliate. So if you didn't, the permanent tooth would push against it and it wouldn't resorb and it would just deflect it. So it has to be resorbable, yeah.
And I think, so this is the last question unless there's more in the chat. Just someone asking if you could explain vertical condensation to them. Yeah,
so the condensation you're probably used to is cold lateral, where you put your GP into the canal and then you push it laterally and condense GP points against each other. But if you've got an open apex or even apexification, you have quite a wide flat apex. You've got a wide apical stop, and it'll be very, very difficult, because you don't have the kind of the point at the apex to place your GP points. So we have GP that's warm, and it squirts like a Mr. Whippy out of a gun, and you just squirt it into the canal and you pack it in. So it's literally warm vertical condensation. You push it in and it will fill any unusually shaped canal as well. It's really fun to use.
Is it used more in peds than other places?
No, I think Mr. Darcy uses it quite a bit as well, because you have adults who have open apices and, you know, internal resorption, and you can't get GP points into that. So you fill it up with warm vertical condensation. Much easier to use, from my point of view. But it's literally just soft GP that squirts out of a gun that you pack in.
Okay, thank you. What determines the success of pulpectomy in primary teeth?
I think probably a few things. The cooperation of the child is one. The skill of the operator. I mean, I think if you don't do pulpectomies and you try one for the first time, it will be a relatively poor prognosis. Also the tooth, so an E would have a much better prognosis than a D, just because of the size of the tooth and you know, the complexity of the root canal system. And it also depends as well, if you have a heavily infected tooth with big facial swelling, then the success will be less than if you have a non-infected, non-vital E, for example. Yeah, but all in all, most of our studies show an 80% success rate, and they're done by people who do a lot of pulpectomies. And quite often those studies, they're done under GA, to be honest. So success rate is guarded.
Thank you. Questions keep coming in. Are you okay with time?
Yeah, no, you're fine.
Can we use warm lateral condensation in perforated teeth?
So with a perforated tooth, you'd be talking about repairing the perforation first, so something like MTA or biodenting, and then you're back to a normal canal, depending on the perforation. So you could probably use collateral if that's what you would already have used, or warm vertical. It wouldn't really matter. I mean, that's all about just repairing the perforation, isn't it? So yes is the answer, if needs be.
If caries was into the mid-third of dentin and no pathology, would you consider horse technique or pulpotomy?
In an asymptomatic tooth, so if you look at the literature in Hall-style crown, initially we thought it had to be a very small caries lesion, but we're seeing more and more, if there's a dentine bridge between the caries and the pulp, and it's asymptomatic, you can actually place a Hall-style crown.
Do you have any more questions?
Oh, there we go.
Oh, there we go. Sorry, we didn't hear any of that.
Oh, sorry, what was I asked? What was the question? I can't remember. Oh yes, if there was caries into the inner half of dentine.
If caries was into the mid-third of dentin and no pathology, would you consider horse technique or pulpotomy?
I'd probably consider a whole technique, because the new literature shows as long as you have a band of dentine between the caries and the pulp, you can use a Hall-style crown and it works nicely, as long as it's an asymptomatic tooth. The one time I wouldn't, if it was extensive decay and I was planning a general anaesthetic to extract other teeth, I'd be more likely to take it. But if the child was cooperative and I was doing everything under local, yeah, I would. Absolutely.
That makes sense.
Yeah.
I think that's the last question now. After extraction of a tooth, what methods, if any, do you commonly use to maintain space for eruption?
In my cohort of patients, none, to be honest, because there's such high caries risk. And if you place a space maintainer, you increase their caries risk. If it's someone who isn't high caries risk and I'm losing one tooth, you could do something like a band and loop. That would be the most common. The literature suggests space maintainers, most of them don't last beyond a year. But there was a very nice paper in space maintainers in BDJ that I've done with one of our core trainees, if anyone's interested, and it goes through all the different techniques you could use.
What's the name of that article?
It's maintaining space in the primary dentition, a necessary intervention or step too far. I think that's the title. I can send it to you if you want.
Yeah, we'll put it on our Instagram, and then people can read it after.
It's either just been published or about to be published, but yeah, I'll find it. Yeah.
We'll get Mel to post it on the recommended BDJ articles.
There you go.
There we go.
Yeah, that's all the questions. Thank you. Thanks everyone for listening. Don't forget to get your certificates. So I know Owen's already said. Next week we've got one of our own again, moving on, talking about blood coagulation, part 1. So that should be good. Thanks again, Prof. Barry, for having us.
No problem. Thank you.
Thanks very much. Cheers. Appreciate it.